Hello, I'm Matt Line, and this is part 4 of Thoracic Ultrasound. In this lecture, we're going to cover the differential diagnosis algorithm and case examples to help you understand all the points covered. So, here's our thoracic ultrasound diagram. You have a patient that comes in with acute shortness of breath, and you decide you're going to do a thoracic ultrasound. The first question I ask is the lung or the image that I'm getting, is it airy or not airy? And what do I mean by airy? Well, this is normal lung ultrasound. We've placed our probe across the ribs, we can see the pleura, and we can't see anything deep to the pleura. This is a normal airy ultrasound. That tells us a lot of information. Let's talk about the non-airy ultrasound. If it's not airy, then I think that there must be something in there, and generally that's going to be fluid. If it's fluid outside the lungs, as we see with a pleural effusion, that tells me that it's a pleural effusion. If it's fluid inside the lungs, then I start thinking it's pneumonia or a possible PE. So, fluid inside the lungs with air bronchograms, I think pneumonia, hepatization as we talked about before, and possibly a very large pulmonary infarct. This shouldn't be hard to distinguish because it should be severe enough that you can tell this on clinical grounds. If I see fluid outside the lungs, then I start thinking, this is a pleural effusion. I want to tell how big is the pleural effusion. I want to know if it's a transudate or an exudate by detecting whether it's a simple or complex pleural effusion. And then I have to decide, is this a cause of the patient's shortness of breath, or is this a symptom of another process that's going on? If it's airy, then I want to know a few other things. I want to know, is the lung sliding or not? Is the sliding lung sign present or not? If the sliding lung sign is not present, then I'm going to think pneumothorax. Again, I need to be scanning this patient in the supine position, I need to do a scan on the anterior portion of the chest, and I need to look for the lung point. If the patient is intubated, then I could have a couple diagnoses in mind. It could be that I have no sliding because I have a right main stem intubation, therefore the left lung is not sliding, or an esophageal intubation and neither lung is sliding. So I better look for the lung point if it's not sliding and I'm considering a pneumothorax. If the lung is sliding, then I want to look at the pleural surface and I want to look deep to the pleura and I want to look to see if there's any B-lines. If there are B-lines, then I'm going to think there's fluid in the alveoli. What does that mean? If there's no fluid, then I think, why is this patient short of breath? They're short of breath and they have normal lungs. What does that mean? Well, that means that I'm going to be suspicious of COPD or asthma, a pneumonia that I couldn't see or a PE that I couldn't see, or the patient has increased metabolism and is fighting off an acidosis. They may be Kussmaaling, in other words. But if I see fluid in the lungs, then I know that there's something wrong. If I see B-lines, I know that there's fluid in the alveoli, and I want to know, are the B-lines isolated? Are they dependent? Are they diffuse? If they're isolated, then I'm starting to think this is probably a pneumonia. And if it's a pneumonia, then I want to check the IVC and want to look at the heart for sepsis. If it's just dependent, then I want to check the IVC. If the IVC is big and dilated and the left ventricle has got a low ejection fraction, then I'm going to think this is congestive heart failure. If the IVC is big and dilated and the heart's beating hard, well, maybe it's volume overload. If the IVC is variable, yet I still have fluid in the lungs, then I may be in a hypertensive emergency situation. If the B-lines are diffuse, then I'm going to start thinking that this is ARDS or pneumocystis or maybe a pneumonitis. We talked about this just a little bit before, that PCP or pneumocystis gyrovecii looks like B-lines, but is diffuse. Generally, the IVC is going to be very small because these patients are going to be septic and fairly sick, and it's easy to differentiate that from ARDS, but occasionally it can be more difficult. In all cases, we want to consider what is the clinical history and correlate this to our physical exam. So let's try this with a few cases. So if a 65-year-old male comes in with left-sided chest pain and dyspnea. It started 5 days ago when he was diagnosed with pneumonia. He was started on antibiotics at that time, and he comes in today because he's not feeling well. He's a little bit more short of breath, and he's got a mild hypoxia when you examine him. So here's their x-ray. Can you make a diagnosis from this x-ray? There are several things wrong with this x-ray, but making a diagnosis is a little bit difficult. So let's do our ultrasound. So we place our probe in the mid-axillary line on the left side, and we can see this pleural effusion. We can see the lung floating in it, so we have made one diagnosis. It is a not airy picture, pleural effusion. Is this a symptom or a cause? Are they more short of breath because they have an increasing pleural effusion? Or is this a parapneumonic effusion and is associated with the pneumonia? Well, we would look at the back and we would detect how big this is. If this is a small pleural effusion, then that is probably not the reason why they're getting more short of breath. So we keep looking. So we slide the probe up from the back, and we slide up a rib, and all of a sudden we see lung rockets. These are isolated lung rockets up the back on the left side near the scapular border. And as we come back down towards the base, the lung rockets disappear. So these are isolated lung rockets. And we start thinking, what does an isolated lung rocket indicate? I already told you, that indicates pneumonia. So we've made a diagnosis. We have a pneumonia, and we have a pleural effusion, and the patient's getting worse. Maybe the bacteria are resistant to the antibiotic we have chosen. Maybe it's a different type of pneumonia. But the pneumonia is still present, and it is the cause of the patient's shortness of breath. Here's another case. 45-year-old male comes in with acute shortness of breath. He's got a history of HIV. He's on dialysis. He's got a history of HIV cardiomyopathy. He is hypoxic with a saturation of 91% on arrival. Does not have a fever. Has bilaterally coarse breath sounds and lower extremity edema. So if I were going to make a differential for this, I would start thinking, is this volume overload? Is this pneumonia? Maybe it's CHF because he's got a history of the HIV cardiomyopathy. And maybe it's pneumocystis because he's not on his medicines. So we do a chest x-ray. Here's his chest x-ray. Can we make a diagnosis based on the chest x-ray? You can see there's certainly a lot of abnormalities on his chest x-ray, but this is a little difficult to make a diagnosis. So let's do an ultrasound. So here we've placed our probe on the chest, and we're sliding around and we see lung rockets. As we slide around a little bit more on the right side, we see hepatization. So we know that he has a pneumonia. That was fairly easy because we saw it. It's a pneumonia. So what do the lung rockets represent? They represent interstitial edema, and in this case, that's inflammation. But we also found his pneumonia. But what else do we want to know? Is there anything else you want to know about this patient? Well, since I'm thinking that this is pneumonia, I'd like to know, are they septic? So I'm going to look at their IVC, and when I do that, it is very low or very small. Therefore, the patient needs fluid. And if I look at the LVEF, it is very high. It is hyperdynamic. So I would think that this patient needs fluids, and if their blood pressure starts to fall, then I know they're septic. So this is early sepsis due to pneumonia. How about this case? A 22-year-old female comes in after a car wreck. They were an understrained driver. Their GCS is 9. They're complaining of chest pain. They've got mild hypoxia, mild tachypnea. Their breath sounds are equal, but they've got a blood pressure of 70/40. So we scan the anterior chest. On the right side, we see lung rockets. On the left side, we see normal lung. What is the diagnosis? You're correct. This is a pulmonary contusion. It is causing edema or blood to form in the alveoli where the steering wheel hit their chest on the right side. The left side is normal. This is isolated pulmonary edema or isolated lung rockets, and in this case, that's a pulmonary contusion. What about this case? It's the same case, but this time when we scan, the left lung is normal, as before. The right lung is abnormal. Do you see the abnormality? That's right, there is no sliding lung. This patient is laying supine. There's no sliding lung. Therefore, this is a pneumothorax. How would we confirm that? We would slide around the chest. We'd look for the lung point. Then we know we're looking at a pneumothorax. How about this case? So we slide down. We're doing a fast exam. We look and we see a little bit of fluid on the right side between the liver and the kidney. It's very subtle, but this is a positive fast exam. As we slide up the left side though, we see a large accumulation of fluid. This is after a car wreck. So this would be presumed to be blood, just like the positive fast exam would be presumed to be blood also. It may not be blood, but if you were a betting person, you would guess that fluid in the chest after a car wreck is blood, so this would be a hemothorax. Let's try a different case. 64-year-old comes in, HIV nephropathy, HIV cardiomyopathy, complaining of chest pain, mild shortness of breath, mild hypoxia, but the breath sounds are equal. So let's look. So we're going to scan their whole chest. We scan their anterior chest, we scan their posterior chest, we scan the upper lobes, the middle lobes, the lower lobes. And no matter where we scan, we see the same thing, which is lung rockets. Lung rockets mean fluid in the alveoli. And when we see it like this in a person that has HIV, we start to think this is probably PCP or pneumocystis. So let's look at the IVC. It's very flat. That goes along with the diagnosis of pneumocystis. They're generally fairly sick by the time we see them in the emergency setting. We look at their EF. It is very high. Their heart is ejecting all the blood it can get out. So this patient is not only having a problem with their lungs and they have pneumocystis, they're also septic. So you need to treat both the sepsis and the pneumocystis. Let's take the same case, but this time, as we scan up the right side of the back, we see at the base it is a normal lung ultrasound. As we come up towards the scapula, we see lung rockets. Those are not dependent lung rockets or dependent fluid. That is isolated fluid. If we were thinking about that, what causes isolated fluid? A pneumonia. So let's look at the IVC. We look at the IVC. It's the same as before. It's very flat. The LVEF is very high. So again, this is a pneumonia and the patient is septic. How about this case? Same clinical scenario, but when we scan at the bases, we see lung rockets, and as we come up the chest, they get less and less. And at the top part of the chest, they're normal. We have normal lungs. So in this case, we have dependent fluid in the lungs. So we confirm this by looking at the IVC. When we look at the IVC, it's big and dilated. That goes along with elevated central venous pressure. So we were thinking this is probably CHF. Let's look at the LVEF. And when we look at the LV, the squeeze is very poor. So all of this goes along with congestive heart failure or cardiogenic pulmonary edema. So in conclusion, I hope you see that thoracic ultrasound can have a dramatic effect on your clinical practice. This was just an overview of how to integrate it into your clinical practice. Please remember that a lot of the information you read about thoracic ultrasound has problems, especially research articles. They have problems with how they're doing their systematic approach. Hopefully I've shown you a very easy systematic approach that will help you integrate this into your clinical practice. And once you start integrating it and getting a few examples and correlating it with CT or chest x-ray, you'll see how the knowledge of this can help you differentiate between a lot of clinical entities that can cause chest pain and shortness of breath. I have a condensed lecture of this called How to Read a Chest Ultrasound, and you can find it at the link below. Again, I'm Matt Lyon, EUSacademy.com, Thoracic Ultrasound. Thank you very much.